So hello everybody, I'm Dr. Apurva Satish Amarnath. I'm a consultant reproductive medicine in Nova IVF Fertility in Kamanalli in Bangalore. And today we'll be talking about fertility enhancing surgery and basically what is the role of surgery in the era of assisted reproductive technology. So we would be covering this under three headings, basically the surgeries concerning the ovary, the fallopian tubes and the uterus. So we'll start off with the ovaries because this is one of the most common surgeries that are done. And the main surgeries that we do in terms of fertility would be for endometriosis and the other for PCOS, that is the ovarian drilling. So starting with endometriosis, endometriosis affects about 10% of all women and about 30% of women with chronic pelvic pain. And it affects nearly 40% of infertile women. This could be grade 1 to grade 4. And endometriomas are not seen in all these women. Overall, endometriomas are seen in about 10% of all women with endometriosis and in about 60% of women with moderate to severe endometriosis. So basically, in terms of fertility outcomes of surgery, in mild to minimal disease, it is basically controversial. It is not yet confirmed whether doing a surgery in mild disease is actually helpful. The pregnancy rate between surgery versus no treatment is 58% versus 45%. The fecundity is not different at 6 to 7%. Overall, Cochrane says that laparoscopy may improve pregnancy rates, but it is not completely proven. And Ashermans and RCOG says ablation or lysis is effective. So you can consider doing surgery for mild to minimal disease if you're doing a laparoscopy for any other reason. Like you can see in the video, you can see endometriotic spots. So this is a mild disease. You cannot see any tubal adhesions that are seen. So the tubo-ovarian anatomy is maintained and it's just mild fulguration that is being done. And in this, conservative treatment can be attempted. Now coming to moderate to severe disease, there is severe anatomic distortion that happens when there's moderate to severe disease, basically because of the peritubal adhesions. There is a very low background pregnancy rate. This is spontaneous pregnancy rates in endometriosis, and numerous uncontrolled trials do show benefit of surgery. But you have to remember that infertility, every case of endometriosis doesn't warrant surgery. Surgery is indicated only for very invasive, adhesive, and cystic endometriosis. Conservative surgical therapy with laparoscopy and possible laparotomy are indicated. And very important to remember, there is no role of repeated surgery in endometriosis and fertility. So the first surgery is the only surgery in a patient with endometriosis who is also infertile, and no more repeat surgeries are indicated. Like you can see in the video, this is a case of severe endometriosis where the severe adhesions in the posterior surface, which is attached to the rectum, and also the tubal ovarian anatomy is distorted, and surgery may show benefit. So knowing all this in terms of endometriosis, the most important question is when to operate. Should we even operate on endometriosis? And if we decide to operate, when we should operate? So endometriosis, there is a controversy of the size regarding when endometriosis should be treated. As per ASRM criteria, a cyst of more than 5 centimeter should be operated. And as per Ashermans, a cyst of more than 3 to 4 centimeter can be operated. So if you choose to operate, technique should be stripping of the cyst wall. This is basically to lower the recurrence rate. Avoid damaging the normal ovarian tissue by using as less fulguration as possible. And drainage and coagulation can be done, but that has a higher recurrence rate. So the most pertinent question is, should endometriosis even be removed prior to IVF, especially in a stage 3, stage 4, when the treatment of choice in terms of pregnancy for an infertile patient is IVF? Should we even operate? So what are the implications of endometrioma resection? It basically reduces the follicle growth, so it requires longer stimulation, higher dose of stimulation. There is increased FSH or HMG requirements. There is a lower number of mature oocytes, and there is no change in rates of fertilization and pregnancy in a patient who has operated versus not operated in terms of IVF outcomes. So the only place where this is an Ashermans recommendation where it says that surgery needs to be done for an endometrioma which is more than 4 centimeters is basically just to confirm the histological diagnosis, reduce the risk of infection, and improve the access to follicles. So in case you're planning an IVF and the access to the follicles is difficult because of the presence of the endometriomas, only then surgery is indicated. Reconsider the decision to operate if there's been any previous ovarian surgery, endometriosis or not. It could even be a dermoid removal has been done previously. So in case there's been any previous ovarian surgery, avoid another surgery. It has to be remembered that any surgery for endometriomas reduces the ovarian reserve post-operatively and also reduces the ovarian response to medication. So that needs to be counseled to the patient. And as per the Cochrane 2010 review, there's no evidence of benefit of surgery for endometriosis before IVF. So the only benefit is if spontaneous pregnancy is planned. But like I said, in stage 3, stage 4 treatment of choice is IVF. And prior to IVF, there's no real role of doing endometriosis surgery unless the patient is highly symptomatic in terms of severe pain or it's a very large cyst causing symptoms. So the basic risks associated with endometrioma resection is decreased ovarian reserve. This is basically because the follicles which are adjacent to the cyst are destroyed because of the fulguration that is done. The measurable changes that we see after resection is increased ovarian resistance to ovulation induction, decreased oocyte number and quality for IVF, and sometimes premature ovarian failure. This is at a risk of about 2% if bilateral endometrioma resection is done. So in case we do operate for endometriosis for any reason, there are some points that need to be remembered. That is to minimize the total number of surgeries, use the least invasive approach, that is laparoscopy, minimize the tissue trauma, remove all disease. This is basically as much as possible, and consider adhesion barriers. But at this point, there is no evidence of any benefit in improving the pregnancy outcome by using adhesion barriers because post-surgery, there will be reformation of the adhesions. So overall, in terms of management of endometriosis and endoscopic surgery, surgery well performed is effective treatment in all stages of endometriosis and endometriomas in infertility and pain. Ovarian suppression is generally effective for pain. So if pain is the only symptom, then suppression should be sufficient. Repeat surgery is of limited benefit and actually can be detrimental for fertility. Pre-IVF treatment, suppression is usually sufficient. Surgery is done only in case of large endometriomas. And endometriosis endometriosis surgery as such has no effect on the IVF live birth rate. So this would be about endometriosis. So the basic take-home message for endometriosis is, as much as possible, try avoiding doing a surgery and counsel for IVF as soon as possible, because the sooner the pregnancy part is taken care of, then surgery can be attempted to treat the endometriosis. Next, coming to PCOS. Now, I don't have to really go into details about PCOS. I'm sure all of you are dealing with the implications of PCOS and the problems it does cause. So the first line of treatment in PCOS, as you all know, is lifestyle modifications. Body weight control is required, which with the aid of diet, exercise, and sometimes even pharmacological agents and bariatric surgery. Clomiphene citrate and letrozole, oral medications are the first choice. The second line of treatment would be gonadotrophins and laparoscopic ovarian surgeries. So these both gonadotrophins and laparoscopic ovarian drilling is basically the second line of treatment. And this is the alternative treatment for women resistant to clomiphene with minimal risk of multiple pregnancy and OHSS. So what is ovarian drilling? This is basically a laparoscopic wedge resection equivalent for PCOS. Electrocautery or laser is used to destroy part of the ovaries, and ovulation usually temporarily resumes in most women. So the indications of ovarian drilling is clomiphene citrate or letrozole resistance, where even with increasing dose, there is no ovulation happening. So it's important to remember that if ovulation is happening with oral agents, please do not do ovarian drilling, which means that they are responding to medication and ovarian drilling is not really going to change their outcome. Only in patients who are resistant, in the sense that oral agents are not acting for this patient and there is no ovulation that is happening, only then ovarian drilling can be considered. Patients undergoing laparoscopy for tubal patency, at the same time drilling in a confirmed case of polycystic ovaries, and a poor response to any of the ovulation induction agents. So the technique of ovarian drilling is uterovarian ligament is grasped using a grasper, moving the ovary towards the anterior abdominal wall and in front of the uterus. Using a double insulated retractable needle electrode connected to a electrosurgical generator, 40 watt is used and 4 to 5 points, puncture points are given. And each crater should be 1 to 3 millimeters in size and 4 millimeter in depth, and stay away from the tube and the peritoneum. This is basically to reduce the formation of adhesions. So how does ovarian drilling act? Ovarian drilling basically causes the destruction of the ovarian stroma, which in turn causes marked decrease of the circulating level of androgens, that is the DHEA and testosterone, decrease in the circulating level of estradiol, reduction in the concentration of LH and as well as the LH bioactivity, decreases the LH-FSH ratio, temporary decrease in the inhibin levels, which also means the AMH levels are falling, removes the intra-ovarian block to follicular maturation that precedes ovulation, resulting in the recruitment of new cohort of follicles and subsequent ovulation. So the outcomes with ovarian drilling are basically, it causes an ovulation rate of around 50 to 90%. Ovulation occurs within 2 to 4 weeks and menstruation usually happens within 4 to 6 weeks. Cumulative pregnancy of nearly 76% and live birth rates of 64%. Improvement in reproductive performance is sustained for many years, but it needs to be remembered that the first 1 year is basically where most of the patients conceive, and if pregnancy has not happened within 1 year of laparoscopic ovarian drilling, then they need to be counseled for the third line of treatment, that is the IVF. 49% of women usually conceive within the first 1 year of treatment, and there's no significant differences in abortion rates with laparoscopic ovarian drilling and gonadotrophins. So who are the poor responders to LOD? It is important to remember what are the selection criteria. So women who have a high BMI, that is more than 35 kg per meter squared, a serum testosterone more than 4.5, free androgen index of more than 15, that is the testosterone divided by SHBG into 100. Poor response is seen in women with early menarche, low LH-FSH ratio, low serum glucose levels. Preoperative LH-FSH ratio is most indicated. So when you're selecting a patient for laparoscopic ovarian drilling, it basically helps most in patients who are normal to slightly overweight, whose preoperative LH levels are high, and the serum testosterone levels are also high. So if any of this does not fit into the criteria, then even after laparoscopic ovarian drilling, the response to ovulation-inducing agents will be low. So it's important to see who it needs to be done for, and should not be done indiscriminately, because there are a lot of patients where the ovarian reserve drops drastically after ovarian drilling. Another factor is age. So younger the age, the better the response. The older the age, the worse the response. So patients less than 27, 28, ovarian drilling can be considered, but above that, they need to move on to further treatment. The complications of this procedure would be adhesion formation, whatever surgical risks are associated, anesthesia, and premature ovarian failure, This has not really been reported. It's more of a theoretical complication, and this can be seen in overzealous ovarian drilling, not if you stick to 4 to 5, or it can be seen in patients who are incorrectly selected, or drilling has been done because of a polycystic appearance on laparoscopy, but not really a diagnosed polycystic ovarian case. So that is about the ovaries. Next, we would move on to the surgeries on the fallopian tubes. So tubal surgery in the era of assisted reproductive technique has actually taken a backseat. There are not a lot of tubal surgeries that are done anymore because of the success of fertility treatment in comparison to corrective surgery. But some of the considerations that need to be taken if tubal surgery is considered is the age of the patient, the ovarian reserve of the patient, prior fertility, the number of children that they are actually desiring to have, the site and extent of the tubal disease, presence of other infertility factors, the experience of the surgeon who is operating, and the success rates of the IVF program, patient preference, religious beliefs, cost, and insurance reimbursement also does come into the picture. And most importantly, before considering surgery, a semen analysis should be done, because in case of a poor male factor, post surgery, even if done well and successful, the treatment might be an IVF, so there's no need to put her through an unnecessary procedure. So tubal surgery can be considered in women who are young with good ovarian reserve, who probably had a child or two already and are looking to have multiple number of children with a good amount of anatomy that is functional. So there are the tubal blockage or tubal issues would be divided basically into the proximal tubal blockage, that could be the corneal spasms and the corneal blocks, and the distal tubal blockage. Proximal tubal blockage accounts for about 10 to 25% of the cases. In this scenario, tubal cannulation is the treatment of choice. For this, confirmation of normal distal tubal anatomy has to be done using laparoscopy. While doing tubal cannulation, it is important to note that if the obstruction is not overcome by tubal cannulation with gentle pressure, a true anatomic occlusion has to be assumed and the procedure is terminated. So there should not be increased pressure in trying to cannulate a patient because that can cause the tube to basically open up. In such a case, IVF is preferred to a resection and microsurgical anastomosis. Approximately 1/3 of the open tubes, that is of the proximal tubal blockage, do reocclude. So pregnancy has to be planned as soon as between 3 to 6 months of the procedure. Next, coming to the distal tubal disease. Distal tubal disease most commonly is Hydrosalpinx or fimbrial phimosis that is seen. This is mainly seen due to PID, peritonitis, and prior surgery. So there are patients who have good prognostic factors and poor prognostic factors, and this does help in deciding in whom extensive surgery needs to be considered. Mildly dilated tubes, that is less than 3 centimeters. I'm sorry about that. The good prognosis basically would be the ones who have limited flimsy adhesions, mildly dilated tubes that is less than 3 centimeters with thin pliable walls, and a lush endosalpinx with the preservation of the mucosa. So procedures that can be done for distal tubal disease, basically peritubal adhesions from any of the above causes or even endometriosis basically impair the ability of the tubes to capture an oocyte because they disrupt the anatomic relationship between the distant fallopian tube and the ovary. So one study reported basically a cumulative pregnancy of around 40% in 12 months after adhesiolysis by laparotomy versus 8% in the untreated group. Laparoscopic neosalpingostomy and fimbrioplasty also can be done by opening a hydrosalpinx or increasing the opening for fimbrial phimosis respectively. The pregnancy rates after these procedures basically depend on the degree of the tubal disease and are more favorable with good prognosis patients. Intrauterine and ectopic pregnancy rates after neosalpingostomy can be high, where pregnancy rates are about 58 to 77% with a ectopic pregnancy of 2 to 8%. For severe disease, these values are about 0 to 22% with an ectopic pregnancy rate as high as 17%. So as you can see from this, the surgery for extensive disease is not really advisable because of the complication rate that especially the ectopic pregnancy rates are high. So if a surgery is done for tubal pathology, it needs to be remembered that there should be mild pathology, mild adhesions, and the tube is not severely affected so that the risk of ectopic pregnancy is low. So in patients who have poor prognosis, that is extensive dense peritubal adhesions, massively dilated tubes with thick fibrotic walls, and sparse or absent luminal mucosa, laparoscopic salpingectomy is indicated. And sometimes if it is difficult to do an entire salpingectomy, at least a tubal disconnection at the cornual end is to be done so that the connection between the tube and the uterus is removed. So why do we need to remove the hydrosalpinx? Why can't we leave a hydrosalpinx in situ, and why do we need to operate on it? Because anyway, for a hydrosalpinx, since there's a tubal block, we will be planning an IVF. So a lot of studies basically have shown that the presence of hydrosalpinx does reduce the pregnancy rate because the fluid of the hydrosalpinx is actually toxic to the embryo. So as you can see from the rates in tubal infertility for other causes other than hydrosalpinx, the pregnancy rate is around 31% as per this study. And with hydrosalpinx, it is around 16.4%. So the pregnancy rate is nearly 50% lower, and this would be the same for fresh ET and frozen embryo transfer. And the miscarriage rate in the presence of a hydrosalpinx which has not been treated is 2.3 folds higher. So in case of a hydrosalpinx, when do we operate? So the basic decision for surgery is basically ultrasound. So if there is an ultrasound visible hydrosalpinx, the pregnancy rates are lower and the cumulative pregnancy rates are also lower. So an ultrasound diagnosed or an ultrasound visible hydrosalpinx, a surgery is indicated to remove it. But in case there's a hydrosalpinx that is not visible by ultrasound, IVF outcome is not actually reduced, so it does not really require a removal. So next, coming to the technical aspects of a salpingectomy. As you can see in this video, it is important to coagulate and divide the tube close to the cornua itself. Serially coagulate and cut the mesosalpinx. Stay as close to the tube as possible to avoid thermal injury to the ovary and vascular injury of the ovarian blood supply. So stay as close to the mesosalpinx as possible so that the coagulation and the cutting is done very close to the tube, and there is no blood supply that is affected to the ovary, because the ovarian function should not be affected in this surgery. So in terms of outcomes in fallopian tube infertility, this treatment plus IVF work. This is an old study done in 1999, and it is shown that laparoscopy and treatment, that is salpingectomy versus just a laparoscopy and diagnosis, there is an increased pregnancy rate at around 23.7%. As per the other study, there's a delivery rate of 28.6% versus 16.3% in patients with treated hydrosalpinx. And on an ultrasound diagnosed hydrosalpinx, which is treated, 40% versus 17.5% where there's no treatment. So the outcomes basically are Numerous studies show that Hydrosalpinx has a detrimental effect on IVF success rates. Two meta-analyses showed that the pregnancy rate, implantation rate, and delivery rate were 50% lower, and that spontaneous abortion rate was higher in the presence of Hydrosalpinx. This finding basically is due to mechanical flushing of the embryos from the uterine cavity, which decreases the endometrial receptivity and also has a direct embryotoxic effect. Patients with Hydrosalpinx visible on ultrasound may be more significantly affected. RCTs, which compare pregnancy rates and outcomes with IVF for women with Hydrosalpinx with or without prior laparoscopic salpingectomy, basically reported that the post-salpingectomy, the rates of pregnancy and live birth is similar to those of women without Hydrosalpinx. This is in the setup of an IVF. So there are newer techniques where proximal tubal occlusion is tried for Hydrosalpinx. This is by hysteroscopy. Assure coil inserts are trying to be used, but it is seen that the trailing coils within the endometrial cavity may have the potential to act as an intrauterine contraceptive device. Complete tissue encapsulation of Assure coils was observed by hysteroscopy only in 17% of patients within 1 year after placement, and in 25 after 13 to 43 months. So currently it is not really being used, but this is something that is being looked at and studied. So in conclusion, for the fallopian tube surgery, that is the surgical treatment for tubal disease in women who undergo IVF, surgical treatment should be considered for all women with Hydrosalpinx prior to IVF treatment. Laparoscopic tubal occlusion is an alternative to laparoscopic salpingectomy in improving IVF pregnancy rates. Further research is required to assess the value of aspiration of the Hydrosalpinx prior to or during IVF procedure, and also the value of tubal restorative surgery as an alternative to IVF. The next fallopian tube pathology would be peritubal adhesions. The presence of peritubal adhesions basically has an effect equal to a unilateral tubal block, and there's a 25% reduction in the pregnancy rate. So as you can see, the effectiveness of adhesiolysis in patients who were not treated with adhesiolysis for peritubal adhesions had a pregnancy rate of around 11% at the end of 1 year and about 16% at the end of 2 years. Whereas in a patient who has undergone adhesiolysis, there's a pregnancy rate of 32% at the end of 12 months and 45% at the end of 24 months. But it's important to remember that this would be basically for flimsy adhesions. Anything with dense adhesions, even post adhesiolysis, the pregnancy rate is not really going to be all that different. Next in terms of fallopian tube would be surgery for sterilization reversal. In patients who have undergone a prior tubal ligation, the decision regarding whether to undergo tubal reanastomosis or directly do IVF should basically take into consideration the pros and cons of each treatment for that individual couple. The age of the patient, the ovarian reserve of the patient, and also the current semen analysis should be the factors that need to be looked at before even considering treatment. Tubal anastomosis should not be considered when the final tubal length is less than 4 centimeters. There are significant tubo-ovarian adhesions when there is stage 3 to 4 endometriosis, and if there's more than a mild male factor. So up to a mild male factor, that is slight motility issues or slight morphology issues, it's acceptable to do a sterilization reversal, but anything more than that would require an IVF. So sterilization reversal, that is a tubal reanastomosis, should not be considered. Next, coming to the uterine pathology and the uterus surgeries that would be planned. The most common conditions that affect infertility are myomas. The submucous myomas do affect pregnancy, and intramural, some of the intramural can. Endometrial polyp, intrauterine synaechiae, Mullerian anomalies, and adenomyosis. Uterine anomalies have been reported in as much as 21 to 47% of patients who are undergoing IVF cycles. So first coming to a myoma, the submucous myomas are the most important ones that really decrease the fertility. This basically decreases the normal vascular supply to the trophoblastic tissue and does not, and sometimes even impedes implantation itself in happening. It's present in about 8% of infertile women. So when do we remove the myomas? The main reason for removal of myomas is symptomatic fibroids where there's menorrhagia or there is pressure symptoms that are related to the size of the myoma. In infertile patients where there is a myoma diagnosed, it needs to be removed. All the intracavitary and submucosal fibroids do need to be removed irrespective of the size. Intrafemoral fibroids more than 5 centimeters need to be removed. And in case infertility has been treated, there have been embryo transfers, but still there's no pregnancy happening in spite of, even though the fibroid is intramural or subserous, then removal can be considered. So to remove the myomas, especially in the intramural myomas, they basically distort the cavity. Even though they're not inside the cavity, they do distort the shape of the cavity, which reduce the chances of conception. In intramural myomas that are not distorting the cavity, there's controversial results in terms of surgery treatment. This is basically because the uterine wall is not more than 2 centimeters in thickness, and all intramural fibroids above 5 centimeters do have some submucous component. So surgery can be considered. So the current guideline for this is basically if the junctional zone, that is the zone between the endometrium and the myometrium, is distorted or affected, or if the distance between the junctional zone and the myoma is less than 7 millimeters, then surgery needs to be considered. So in terms of treatment, hysteroscopic myomectomy is the treatment of choice for submucous myomas. There's something called the step W classification for the complexity of the myoma. The myoma removal. And scoring is given based on the size, the position of the myoma, the extension of the base, the penetration, and whether it's on the lateral wall. So this is a scoring system where a score of 0 to 4 is a low complexity hysteroscopic myomectomy where the myoma can be removed easily. A score of 5 to 6 is a high complexity hysteroscopic myomectomy, and this may require a 2-step because sometimes the entire myoma is not removed in 1 step. And a score of 7 to 9, consider other alternatives to hysteroscopic techniques because this would be quite a complicated procedure. So coming to the outcomes, myomectomy of a submucous fibroid, it significantly increases the pregnancy rate and decreases the miscarriage rate. There is insufficient evidence from RCTs to basically evaluate the role of myomectomy. This would be all kinds of myomas to improve fertility. Pregnancy outcome after myomectomy, miscarriage rates are reduced as per this paper to from 41% to 19%. So next, coming to the endometrial polyps. Endometrial polyps are basically small outgrowths in the uterine cavity. A lot of them are not diagnosed at all because it's difficult to pick up on ultrasound. There are nearly 50% of cases which are missed on ultrasound. The basic impact on fertility would basically depend on the position. Anything that's in the fundus of the uterus or the upper body will affect the pregnancy chances. And there are controversies regarding the size. It is said that polyps of less than 1 centimeters do not affect the pregnancy chances, but positionality is more important. It is present in about 24% of infertile women and present in more than 50% of ovulatory women with mid-cycle spotting. Now, as you can see in the video, polypectomy is being done. Basically, using a scissor, the base of the polyp needs to be cut, and then the polyp is held with a grasper and pulled out. So it's important to catch it at the base. Otherwise, there'll be a part of the polyp remaining, and there will be a regrowth of that happening. So in terms of pregnancy rates after polypectomy, there is a 61% pregnancy rate, 52% delivery rate post polypectomy in the first 3 to 18 months post procedure, and there is a reduction in miscarriage rate. This is spontaneous pregnancies also. Next, coming to intrauterine synaechiae. The intrauterine adhesions, basically the incidence is increasing worldwide. The incidence increases in women who have undergone DNC after delivery or missed abortion, tuberculosis, and uterine insult happening in immunocompromised patients. It is seen in about 6 to 20% of women with primary infertility, 25% of women with recurrent abortions, and 25 to 40% of women after postpartum DNC. 6% of women with 2 or more failed IVF with good quality embryos can have adhesions, and it is found after myomectomy, uterine artery embolization, and infection. About 43% of women with Ashermans present with infertility. So the basic impact of fertility is proportional to the degree of scarring, and this is dependent on the density of the adhesions, the degree of the cavity occlusion, and the scarring on the uterine wall. As you can see in the pictures, the one is of the ultrasound where you can see the synaechiae that are seen. This is using an SSG, and this is a hysteroscopic picture of a uterine synaechiae. Therapy of Asherman syndrome would basically be hysteroscopic adhesiolysis. The patient needs to be counseled about the risk of recurrence of adhesions. This would be nearly at 20 to as high as 60%, depending on the severity of the initial adhesions. And the prognosis also is poorer with the increase in adhesions. Methods to basically prevent the recurrence is using OCPs, intrauterine devices, Foley's balloon, hyaluronic acid, estrogens. And a second look hysteroscopy is necessary post an adhesiolysis. This is usually done after 3 months of procedure to see if the uterine cavity is normal and to check whether therapy can be given in terms of getting pregnant. So in terms of success rates of Asherman's therapy, pregnancy rate of 28.7% is seen before surgery and about 53.6% after hysteroscopic treatment. Women with 2 or more previous unsuccessful pregnancies attempts, the live birth rate improved from 18.3 pre-op to 68.6%. The pregnancy rate after treatment in women with infertility is around 45.6%. Again, the successful pregnancy rate after treatment in severe cases is lower. That is, as it can be less than 33%. For women with previous pregnancy wastage, both the pregnancy rate and live birth rate after treatment are around 86 to 77%. And for obvious reasons, the lesser the adhesions, the flimsier the adhesions, the higher the pregnancy rate. And the worse the adhesions or the more dense and the more the amount of scarring, the lesser the chance of pregnancy. Next, coming to Mullerian anomalies. This affects about 0.2 to up to 10% of the general population. The most common treatable anomaly is the septate uterus. This basically, the septum itself decreases the vascularity, which causes recurrent abortions. The other types that are seen are bicornuate, didelphys, and T-shaped uterus. Coming to the outcomes. In terms of treatment, uterine septum is the only one that can be treated and should be treated, and it should reduce to a septum of less than 1 centimeter. Only then pregnancy chances are good. In patients who have a uterine septum, 14% IVF failure rate is seen versus 6% failure in patients who do not have a uterine septum. After repair, both groups are equal and the miscarriage rate drops from 91% to 17%. So as you can see in this video, there is a partial uterine septum extending up to mid-cavity. Using a scissor or a resectoscope, depending on which you're comfortable. As a fertility person, I prefer using a scissor as less electricity as possible inside the uterus. And the scissor cuts right at the middle of the septum. Across, it has to be cut. And you can see these white fibers, which are basically opening up and the cavity is becoming bigger. This uterine septum removal basically doesn't have any tissue that is removed. It is just that the nick is given and the uterus basically opens up and the cavity becomes normal, as you can see by the end of this video. So before doing a uterine septum repair, it needs to be confirmed whether this is a septate uterus or whether there's a bicornuate component to it. These can be done by two methods. One is using a 3D ultrasound to make sure that there is a smooth uterine fundus and there is no bicornuate or diadelphys that you're dealing with. Because a bicornuate or a diadelphys, if this procedure is done, then you're going to open up the uterus, which is not advisable. The other would be to do a concurrent laparoscopy along with the hysteroscopy so that you know exactly what you're dealing with. This procedure, if you're doing only a hysteroscopic procedure following a confirmation by ultrasound, I would suggest doing part of it at least under ultrasound guidance to make sure that you're not cutting too much. So now, as you can see, the cavity has opened up and the space within the cavity is good. And post-uterine septum dissection, about 8 weeks needs to be given prior to planning pregnancy. So the prevalence of uterine anomalies in asymptomatic patients who are undergoing IVF can be anywhere between 11% to 42%. There is a 37.5% clinical pregnancy rate without any intrauterine lesions versus an 8.3% clinical pregnancy with lesions. So as you can see, it is important to treat any uterine anomalies or abnormalities. This could be any myoma, it can be a polyp, it can be Ashermans syndrome, and it can be a septum. But treating this would improve the chances of pregnancy. So the most pertinent question is, should office hysteroscopy be a part of routine infertility evaluation? So it has been found that about 40% of patients who are undergoing IVF, or especially patients of recurrent IVF failure, have intrauterine pathology. As per the study by Hinckley et al., basically 32% of patients presented with polyps, 3% with myomas, 3% with adhesions, 0.5% with septum, 0.3% with retained products of conception, and 0.3% had bicornuate uterus. Now, it is important to remember that a lot of these diagnoses can be made by other methods, which is your ultrasound. It can be done with a HSG. It can be done basically non-invasively. So it doesn't require that there is an absolute routine that is done for every infertile patient, and office hysteroscopy is not needed. But in women who have long-standing unexplained infertility, or there is a suspicion of a pathology, doing a hysteroscopy would be better. So this is basically endoscopy in fertility practice. These are the common procedures that are done by us. If you have any questions right now, I would like to take them.
Thank you, ma'am. Thank you very much for this presentation. I mean, you have covered all the topics and the flow was amazing. So thank you very much. Yes, requesting doctors, if they have any questions, then put a question in the comment section so that I can read out those questions to Apurva, ma'am. Thank you, ma'am. Thank you very much.
Thank you.
Ma'am, to begin with, I have a question, if you allow me.
Sure, go ahead.
Ma'am, as you said, in PCOS women, the second line treatment would be either drilling or the injectable gonadotropins. Ma'am,
Yes.
how do you decide the right patient for the drilling and for the gonadotropins?
So, see, as a fertility person, I prefer to be as conservative as possible. I don't operate unless absolutely required. And gonadotropins and laparoscopic ovarian drilling have found to be equally effective. So the only places where I really choose a laparoscopic ovarian drilling is if the patient is quite young. This is usually less than 25 with PCOS, with high LH and normal to near normal BMI. And these are patients who cannot come routinely for follow-up, because gonadotrophins, one of the issue is once we give it, there is a regular follicular scan that needs to be done. Only then we can continue medication, because gonadotrophins just can't be given and they cannot be sent home. So it's a very small subset of patients where ovarian drilling is the first choice. So my usual protocol is I give them oral agents. If that doesn't work, move on to gonadotrophins. If gonadotrophins doesn't work, ovarian drilling is not an option, because both of them are equally effective. If gonadotrophins doesn't work, then I move to an IVF for these patients. So the only is when they are young and they cannot come for follow-ups, provided they fit the other criteria where the BMI is normal and the LH levels are high and the FSH-LH levels are high. I mean, the FSH-LH ratio is high.
Yes, ma'am. And the success rate is similar, so it's a very small subset, as you rightly mentioned.
Yeah. And the complication rate does increase with the ovarian drilling because it does cause peritubal adhesions. So we are increasing another infertility factor basically by introducing a tubal factor because we did a surgery. And poorly selected patients in terms of the fact that there are a lot of patients who have undergone ovarian drilling where they have no clear diagnosis of polycystic ovaries. So I do see patients where drilling has been done and their ovarian reserve has become nearly practically nil because the selection was not done properly. So it's as much as possible, avoid ovarian drilling, use gonadotrophins. If that doesn't work, counsel them for IVF and move forward. That's
right,
what we need to do.
Ma'am, and in case of endometriosis, also the mild cases, there is a role of surgery. So how routinely this is followed?
Minimal to mild disease is very difficult to diagnose on ultrasound. There is no findings as such. Usually it is picked up on doing laparoscopy for other reasons, either because you're suspecting a tubal pathology or there are people who do diagnostic histolaparoscopies. So when it is incidentally found, fulguration can be done, but there is no role of routine diagnostic histolaparoscopy in infertility currently, because the pregnancy rates are not all that different with treated versus untreated endometriosis. There is still a lot of controversy on this. There's no definitive answer that doing surgery for every patient of endometriosis does help. But moderate to severe disease, IVF is the indication. As much as possible, do not operate.
Yes, ma'am. And of course, as you rightly mentioned, I mean, there is no second surgery for this patient. So
Yes. So endometriosis surgery should be done in experienced hands, especially since laparoscopy is preferred. Since the first surgery is the best surgery and the only surgery that an endometriosis patient should ideally undergo. So that is also important. Knowing the surgical strengths and limitations of yourself would be the most important thing, so that you can refer a patient to a person who can do a good surgery. Especially if you're dealing with fertility. Now, if fertility is not an issue, then it doesn't matter. Even laparotomy can be done and full debulking of the endometriosis can be done. But in infertility, we need to be conservative because we need to save the ovarian reserve, basically.
Right, ma'am.
In minimal to mild endometriosis, routine surgery is not something we look at in every patient who has unexplained infertility.
Right, ma'am. And ma'am, the last question, in case of fibroids or the polyps and the patient coming with infertility, so should they always undergo surgery or how to proceed?
So in patients of polyps, it is better to undergo surgery because usually on ultrasound, we pick up one polyp and doing a hysteroscopy, you can see 2 or 3. Like the diagnosis of polyp is a little difficult on ultrasound because it just shows as a thick endometrium sometimes. And there's no sure polyp. In terms of myomas, submucous myomas need to be removed. That is basically the ones within the cavity. And the intramural, that is the one within the wall of the fibroid, should be removed when it is more than 5 centimeters or when the fibroid is less than 7 millimeters from the junctional zone. So anything distorting the uterine cavity basically needs to be removed. Anything that doesn't distort doesn't need to be removed. So it has to be taken, decision
yes.
has to be taken on a case-to-case basis.
Correct. Ma'am, I don't find any questions in the comment section. So in case on additional, if you want to share a few tips, then you're welcome. Otherwise, we will close the session, ma'am. It's up to you.
So I'll just summarize.
Yes.
The role of surgery in the era of fertility treatment is actually not very high. We don't prefer to operate a whole lot. There are certain indications, like I said, where there's an endometrial polyp, where there is a fibroid, where doing us, or there is a hydrosalpinx where a salpingectomy has to be done, where surgery needs to be done. But otherwise, as much as possible in infertile patients, avoid surgery. That is the most important take home message of this whole thing. And ideally, get a patient before surgery, get a patient evaluated by a fertility person so that the treatment can be decided and the necessity and need for the surgery is also decided. That's all I need to say.
Absolutely, ma'am. So thank you for that excellent presentation, ma'am. Again, thank you very much. Beautiful slides and beautiful pictures as well, surgical procedures as well, videos. So thank you very much, and thank you from Shield team.
Thank you so much for the opportunity. I hope everybody listening learned something. And if you have any questions, please do reach out to me. Thank you.
Yes, ma'am. Thank you for the support. Thank you. Bye-bye. Good night.
Bye-bye. Good night.